January 1st is December 31st.
So it's never been institutionalized yet.
It's a mountain. I mean, you can imagine.
If we go somewhere else after this,
Yeah, it's not high enough, it's cold enough, whatever.
anyways, we fought them and they left us. Good.
They were great.
Ridiculous.
And then that 2.5-year-old. They're all coming again.
Oh, wow.
January 15th.
Scheduled already.
Not more custom. That's the one you mean. Okay, yeah. I saw because one and I was like, wow, yeah. Then I read it. Yes. And I went by on Tuesday and it was looking really sexy. It's well used though. Yeah. Picture of you on the artificial turf. Usually I would rate computer tomorrow. It's computerized tomorrow. Yeah, when it's computerized, absolutely. So is it so much? Here's the thing. It's for a paper. It's paper print. It's not mine. I think but the journal wants to change it to computerized, which means that's probably what they use. Okay, so it's like should be computed. This is the journal. So do you tell nature no, it has to be computed, not computerized? It's from Michael Taylor. He's a so I'm like well, because it's like old, right? It's like maybe, or maybe they just have standards that they use in it. That's what they use. We'll be doing the same. Maybe I'll go work. I'm not going to talk to RMP twice a day. Like respond with regards to the paper version of the paper. I'm sure she has like 24 hours. There's like 50. Well, that's only a time. And they've also done yes, exactly. So the NPM no, we got rid of all. Good morning, everyone.
Your attention, please. Code blue, 14A, room 737, 610 University. Code blue, 14A, room 737. Code blue, 14A, room 737.
Good morning. Welcome to RMP Rounds. It's with pleasure that I welcome Erin Kennedy to be our speaker this morning. She's a surgeon. We work with her closely in the GI group. She leads a clinical research program in patient safety and oncology with main focus to develop and evaluate implementation strategy to improve patient care in terms of quality, safety, and efficiency. Currently, she leads a number of research programs and in particular pan-Canadian initiatives looking at the quality of the effect of using MRI to select prognosis patients in stage 2 and stage 3 rectal cancer with the nice name of QuickSilver. So I want to hand over to Erin to tell us about the current management of rectal cancer.
Thanks, Rebecca, and I'd like to thank you for having me today and everybody for coming bright and early this morning on a Thursday before the holidays. What I'd like to do today is provide a current update on the multidisciplinary management of rectal cancer, really by reviewing recent and ongoing trials for rectal cancer with a focus both on TME surgery and also organ-preserving strategies. And I'd like to focus a little bit more on organ-preserving strategies, as that seems to be sort of a new emerging hot topic in rectal cancer and something that we're talking about a lot more at MCC and Rectal Cancer Rounds. So when I first started, I thought that the management of rectal cancer was pretty straightforward. Rebecca and company provided us a great guideline that said that all stage 2 and stage 3 rectal cancer patients should get preoperative chemoradiotherapy. And this was based on several large randomized controlled trials that showed that preoperative radiotherapy decreases the risk of local recurrence. But the problem, or what's happened, is that those randomized control trials are now a little bit older, and they don't really reflect exactly what we're doing in clinical practice. None of these randomized control trials used MRI. Most of them did preoperative staging with digital rectal exam, and only the German study routinely used transrectal ultrasound to stage the patients. And again, since none used MRI, we've found that it's the most accurate modality to predict the CRM, which is our ultimate goal of surgery. And MRI is increasingly being used to preoperatively stage rectal cancer. And in Ontario, it's the recommended modality for preoperative staging. The other thing is that TME surgery, since those trials, has improved. In those randomized control trials, the rate of complete TME was about 50%. And now we're seeing in more current randomized control trials that the complete TME rate is about 70 to 80%. There's also a lot more surgical techniques, including laparoscopic, robotic, as well as TEM and TAMIS. And I'll just, in a nutshell, tell you what those are. They're both transanal techniques, and they're just different platforms, but they both use a sort of an anoscope that allows you to put laparoscopic instruments in through the anal canal and do a local excision. And it allows for us to be able to do local excisions higher up in the rectum rather than just very low where we're doing a traditional transanal excision just with a regular anoscope with no laparoscopic instruments. The other thing I think is that, as you probably are more aware of than me, is that radiotherapy is also improved. It used to be field-based, but now there's 3D conformal, IMRT, VMAT, and brachytherapy. So there's been a lot of changes that have happened since those RCTs have been conducted. And I think that has made the management of rectal cancer a lot more challenging and complex. And it's not as straightforward as it used to be. And this has really led to, I think, two new emerging treatment paradigms that are pretty much diametrically opposed. And there was a pretty interesting article in a debate format in one of our main surgical journals, Diseases of the Colon and Rectum, that these two paradigms were debated. And so the first paradigm is that TME surgery is required to cure rectal cancer. And that's because TME is the only modality that on its own has been shown to be curative in a majority of patients as a single modality. That when we use TME surgery, we've seen a significant decrease in local recurrence from traditional 30% to about 15%. And there has been no RCT in the TME era that's demonstrated a survival advantage with radiotherapy. The second paradigm, which again is diametrically opposed, is that TME surgery is morbid and leads to more functional, in particular bowel and sexual problems, than radiotherapy. And therefore, the treatment focus should really be on preserving the rectum or organ-preserving strategies with radiotherapy alone or radiotherapy plus or minus local excision. So I guess if you're in the TME treatment paradigm that surgery is needed to cure rectal cancer, I guess the question would be, is there anything we can do to improve TME surgery? And there's been a lot of hype about laparoscopic surgery, that this will sort of improve outcomes with respect to when it's compared to open surgery. And this year has been a big year for laparoscopic versus open surgery. There's been 3 recent non-inferiority randomized control trials comparing laparoscopic to open surgery. They've all been very well organized and well done randomized control trials. They've been published in the New England Journal of Medicine and JAMA this year. And unfortunately, all of those trials have shown indeterminate results for the primary outcome, which was positive CRM, complete TME, and local recurrence. What that means in a non-inferiority trial is that laparoscopic is not superior and it's not inferior to open surgery, but it's just not inferior. That's what we know right now. Perhaps the most disappointing thing is, even though the oncologic outcomes were about the same, is that there was no difference in the secondary outcomes. So that length of stay was the exact same, 7 days in open and laparoscopic surgery, and that bowel and sexual function seemed to be the same in both the laparoscopic and open groups, which was really what we were hoping would be the benefit of laparoscopic surgery. So there's no answer to this. I think that the standard probably is open surgery, and we don't know if laparoscopic surgery is the same or superior to open surgery right now. So if we can't make surgery any better, is there anything, if we still believe in the TME surgery paradigm, is there anything else that we could do to try to make this strategy better? And with the use of MRI for preoperative staging, we've been able to look at tumors a lot differently. You can see that this slide shows that both of these tumors are T3N0 tumors, but you can tell that the tumor on the left looks like it's going to behave much differently, and that patient's going to do much better than the patient on the right. And so that's led people to sort of look at MRI to see if we can classify especially T3 patients into good prognosis patients based on MRI and poor prognosis patients based on MRI, and treat them differently than just treating all T3 tumors the same. And in terms of studies that have looked at this, really there's been two prospective studies that have been completed. One is the Mercury study that everybody's probably aware of, and the other is the Occam study that's from a German group. And both of these studies looked at T1 to T3 tumors of any nodal status, N0 to N2, with a CRM greater than 1 millimeter, and tumors 0 to 15 centimeters. And they considered those features on MRI to be good prognosis tumors. And for those patients, they did primary surgery. And you can see that the primary outcome of positive CRM was quite favorable, 3% in both groups, and that the local recurrence rate at 5 years in the Mercury trial was 3%, which is quite favorable to the previous RCTs. The long-term results for the German trial haven't been published yet. Because of that, we've been interested ourselves, and we have a Canadian group with 16 centers across Canada doing a very similar study called QuickSilver or Little Mercury. And we wanted to look particularly at stage 2 and 3 rectal cancers, again with a CRM greater than 1 millimeter, to see if we could actually reproduce the results of Mercury. And we have a planned target of 75 patients, and right now we've recruited about 45 patients, and we're on target to complete this study in June 2016. And we've had quite favorable results so far. We've had 3 positive margins of 45 patients, so a positive CRM rate of about 6%. The other ongoing trial is a big randomized control trial that's come predominantly out of United States. They're also looking at good prognosis, stage 2 and stage 3 rectal cancer patients. They have a very big sample size planned. Their criteria for looking at and staging patients is ultrasound or MRI. And they're seeing if giving FOLFOX, neoadjuvant chemotherapy up front, will cause a 20% reduction in the primary tumor, and if so, they will not give radiotherapy and proceed to TME surgery. The standard arm is the traditional approach of preoperative chemoradiotherapy, followed by TME surgery and then chemotherapy, and their primary outcome is disease-free survival and time to local recurrence. And this trial has been slow to recruit, and probably the results will be available, I would think, in 5 years at the earliest, at the sort of at the current rate that this is recruiting. And this is just a plug for our QuickSilver study again. And then I think another really interesting randomized control trial that will be very important in helping us guide the treatment of rectal cancer is the Repito study. And it's a randomized control trial by Corinne Marizhnan's group. And they're looking at poor prognosis tumors. So and their inclusion criteria is any of these criteria. If you have a T4 tumor, N2 disease, EMVI present, you have an involved circumferential margin, or you have extramesorectal lymph nodes. And what they're doing is they're in the experimental arm, they're giving short course radiation, followed by full neoadjuvant chemotherapy to give those patients chemotherapy up front, followed by TME surgery. And that's versus a control of preoperative chemoradiotherapy, TME surgery plus or minus chemotherapy. And they're looking at disease-free survival at 3 years. Again, with the rationale being if you give the chemotherapy up front, can you improve survival? Now, if you are not in the TME surgery group, or you're a believer in the avoid TME surgery at all costs, this is sort of what's been going on in terms of trials. And this is what lots of groups have been doing, is giving preoperative chemoradiotherapy, followed by a local excision with TEM surgery. And then the other part of the strategy that we don't talk about is if there are issues after the local excision, they usually recommend salvage TME surgery.
Would there
There's 4 studies that have been done looking at early rectal cancer, and 2 are randomized controlled trials expected.
Hello, over on OTN. Can you guys please mute your microphones because you're interrupting our rounds? Yeah, you have to call them to get them to mute remotely.
Okay, perfect. Oh, it's actually about rectal cancer.
So the first randomized control trials is from an Italian group, and they used both ultrasound and MRI to stage patients, and they took a highly selected group of T2N0 tumors less than 6 centimeters from the anal verge. The diameter was less than 3 centimeters of these tumors, and none of them had high-risk features. The experimental arm was to give preoperative chemoradiotherapy 50.4 gray, followed by TEM surgery. And so with the TEM surgery, they do a full thickness excision of the rectum with the mesorectum in that local excision. So it's full thickness, including mesorectum. There is, I guess, some lymph nodes that can be in the specimen, although the full mesorectum is not removed. So there is a possibility of leaving lymph nodes behind in the mesorectum. And they compared this to laparoscopic TME. And their local recurrence rate at 5 years was similar between the groups, 8% in the local excision group and 6% in the TME group. And the overall survival was similar between the 2 groups. I have to say that this randomized control trial was in a surgical journal. It is a little sketchy. I don't think that it's something that we should, it's also underpowered, but it is hard to follow exactly what's gone on in that trial. And I think the TREC trial that David Seberg Montefiore is in charge of and principal investigator will probably be a little bit more useful for us. They've finished recruiting patients. They have 63 patients in their trial, and it was really a phase 2 trial just to look at feasibility, whether they would be able to randomize patients into a trial looking at local excision versus TME, and also a safety trial. So they took T1, T2, and 0 tumors with a diameter less than 3 centimeters that were amenable to TEM surgery, and they gave short course radiotherapy, followed by TEM surgery in the experimental group, and the control group had TME surgery. And the results were supposed to be available late this year, but I haven't seen any of the results of yet. Maybe you guys have seen them, but I don't think they've published them as yet. The next study is the CART study, which is Corinne Marizhnen's group that's done this study, and I think that probably right now this is the best evidence we have available in this group of patients. I like it. I like how you'll see on this it says distal rectal cancer. The number keeps creeping up with this, it's like 6 centimeters, 8 centimeters, 10 centimeters. And that's because actually TEM surgery, the TME surgery is easier the higher you go up in the rectum. It's quite hard to do it low in the rectum than to do a good job, so that people are sort of letting the upper limit of distal rectal, it seems to be increasing. Anyways, they looked at actually T1 to T3 tumors that were N0 on both ultrasound and MRI and were amenable to TEM surgery. And in this group, they had about 30 of 55, so about half were T2 tumors, and then the other half were divided equally between T1 and T3 tumors, and the diameter of these tumors was about 3 centimeters. They gave preoperative chemoradiotherapy, 50 gray or 50.4 gray, to the patients, and this was followed by TEM surgery. Now, if the final pathology after the TEM surgery was T2 or greater, then those patients were recommended to have TME surgery. So that's part included in the strategy. So they had 51 patients undergo TEM surgery. 2 patients died during chemoradiotherapy, which was quite unusual, and 2 patients were lost to follow-up. So 30 of the 51 patients had a local excision and were less than a T2 tumor. 1 of these had a local recurrence and was salvaged with an APR. 17 of the 51 patients had a T2 or greater tumor. 8 underwent TME surgery, and 9 declined to go through with the TME surgery. And in those 9, there were 3 local recurrences, and all 3 required an APR. So overall, there was, if we look at the whole group, there were 4 local recurrences in 51 patients. So that was a local recurrence rate of about 8%. And I think this is probably the best, the most well-done study. It's not randomized, but this is probably the best one at this point in time. The ACOSOG trial was an American study. They randomized, or they looked at 90 patients. It was prospective, sorry, and they staged patients using ultrasound or MRI. And they looked at T2N0 tumors. They had a lot of problems with this study, and it's hard to sort of sort out what happened. They started off giving a dose of 54 gray combined with FOLFOX chemotherapy, and they had to change their protocol throughout the study because there were just so many toxicities related to this protocol, this sort of combination, and eventually had to change it to 50.4 gray with 5-FU and no oxaliplatin. They included both traditional transanal excision or TEM surgery. And you know, again, it's also hard to figure out the exact denominator. It seemed to change throughout the study. But they, out of the 90 patients, were able to preserve 70 of 84 rectums. They don't really describe what happened to the 6 patients in the whole group for a preservation rate of 83%. They had 2 local recurrences, both requiring APR, and a disease-free survival rate of 84%. Now, if you want to get even bolder, there are 2 studies right now that have looked at preoperative chemoradiotherapy, TEM surgery with salvage TME surgery in more advanced rectal cancers, so T2 and T3 rectal cancers. The LEADER trial is a prospective study, also done by an Italian group. They had 63 patients, and they were either a T2 tumor requiring an APR or a T3N0N1 tumor less than 12 centimeters from the anal verge. They used MRI imaging, and they gave preoperative chemoradiotherapy followed by transanal excision or TEM surgery, and then went on to TME if the final pathology from the local excision was T2 or greater. And in this group, 43 of 63 patients went on to have local excision and had pathology less than T2. And at 3 years, there were no local recurrences in this group and 1 distant recurrence. There were 20 patients that had more than a T2 or greater on their local excision. 11 underwent TME surgery, 4 required an APR. 9 declined TME, and there were 2 local recurrences in this group that were both salvaged with surgery. And there's another, and so I think that this study showed similar results to the Quirke study with a preservation rate of the rectum of about 60% and a low local recurrence rate. The Quirke trial is a randomized control trial that has finished recruiting patients, but the results are still pending. And it's a little bit of a complicated schedule, so I just thought I'd put the schedule up there so that it's more clear. But they're looking at low rectal cancer, less than 8 centimeters from the anal verge. That's a T2N3, nodal status unknown at the time, and less than 4 centimeters in diameter. They're giving a preoperative chemoradiotherapy. And if you have a good response with a scar less than 2 centimeters, they're going to they've randomized patients into local excision or a TME arm. They have had 148 patients that they were able to randomize, with 74 patients in each arm. And in the local excision arm of the 74 patients, 26 have had T2 or greater, or R1, and had to go on to TME surgery. So let me just go back. Oh. So they've done, so in that group that we were talking about, 48 of those patients, or 65%, were able to have local excision. And again, they were able to preserve 65% of the rectums. The rest of the results regarding the salvage TME and their results are still pending and haven't been able, they're coming pretty soon. And they've had some abstract of some very general results right now. So some of the issues with this approach of preoperative chemoradiotherapy and local excision are that, and the authors of these trials are actually the first people to admit this, that the selection of node-negative patients is challenging. And that's one of the reasons that they're recommending TME surgery for the greater than T2 patients, because they think the risk of leaving positive lymph nodes behind is too high. And that's the rationale for that. The other thing is it's very hard to follow up these patients. After they've had a full thickness local excision, there's scarring and fibrosis. And it's very hard to tell whether it's tumor or fibrosis on digital rectal exam and on MRI. So it's hard to follow these patients and know exactly what's going on. It's also concerning that you think they may have a nodal recurrence that you might not pick up quickly, rather than a mucosal recurrence. The other thing is that the salvage surgery usually requires an APR if you think that and it's very technically challenging surgery that you can imagine if they've had a local excision, full thickness. Often we don't close that defect and it's stuck up against the prostate or the sacrum, that most of these specimens come out with a hole in the rectum because there's no rectal wall there. So they're sort of they're challenging cases to do. And that's why a lot of times it becomes an APR, and you might be converting somebody who could have had low anterior resection to an APR. The other thing is that I don't think there's a lot of evidence for this, but Dr. Pucciarelli, who has done a leader study, has some data to show that the functional results following TME surgery after TEM and preoperative chemoradiotherapy seem to be worse if the patients just had an upfront TME alone. So these are some of the issues that have been being talked about with preoperative chemoradiotherapy and the local excision approach when the groups get together. And this has led to sort of, I think, probably renewed interest or some more increasing interest in a wait and watch strategy, or a watch and wait strategy. As you probably all know, there is a surgeon in San Paulo, Angelita Habergama, who over the last 20 years has been instituting a watch and wait strategy at their institution. And she really has the largest cohort in the world of these patients. And you can see these are most of her publications in this area. There's a lot of overlap between these patients. She probably has a cohort of about 300 to 400 patients. But you can see that her results are quite remarkable. The complete clinical response rate is in the 25 to 30% range. The local recurrence rates are between 3 and 5%. Her overall survivals are 93 to 100%, and disease-free survival 72 to 92%. And so these results are quite impressive. And almost, I think, as a surgeon, when we talk about it amongst surgeons, almost sort of too good to be true almost when we look at them. And it really hasn't caught on that there hasn't been any other center that's been able to reproduce her results as of yet. But because of this renewed interest in organ preservation, there are now more studies coming out looking at this approach. One of them is Beets, who's a surgeon from the Netherlands, and I'll talk a little bit more about his study. but his study was published in the Journal of Clinical Oncology in 2011 and showed similar results to Haber-gamma. And I guess it might seem sort of crazy, why would we watch and wait for these patients? And I guess the data really comes from when we do see a complete pathologic response in our patients, those patients do have improved survival. So there's something about these patients where they do better than if you don't have a complete response. And there is a meta-analysis with 16 studies with over 3,000 patients in it that compares the results between about 1,200 patients with a pathologic complete response to those without a pathologic complete response. And you can see, compared to patients without a complete response, patients with a complete response have a much reduced risk of having a local recurrence. They have a much reduced risk of having distant metastases. They have better overall survival and better disease-free survival. So that if the big problem with this is that we can't pick who's had a pathologic complete response before surgery. So if there was a way that we could select these patients, that would be sort of ideal. So one of the ways to select those patients is to sort of wait and watch them. So in terms of Haber-gamma's results, I think some of the major limitations that have come out and some of the reasons that this strategy hasn't been embraced is that her definition of complete clinical response is a sustained clinical response at 12 months. And so it's not a complete response that is assessed at 8 weeks. If you don't have a complete response at 8 weeks, you're sort of pushed out of her trials, and she just keeps the people who've had a good response and keeps them till a year. And when you speak to her at conferences, it's really hard to know what happens if they have local regrowth between 3 and 12 months. We don't know how many patients that was in the denominator. She's never given us a denominator. We don't know how those patients are salvaged or what they do and what the outcomes are of those patients. So there's a real bias towards a watch and wait strategy in her results. Also is that a lot of the patients in her studies are early T1 and T2 tumors, and that even though they've been doing this for 20 years, they haven't provided any quality of life or functional result data for us either. So those are sort of the main concerns with some of her work. So in terms of the BEATS-10 study, it was BEATS-10 is his wife, and it's a prospective cohort study. There were 192 patients with locally advanced rectal cancer in this study. It was any T3 or T4 tumor with a threatened or involved mesorectal fascia, and or if they had more than 3 lymph nodes that looked positive on MRI. It included both mid and low rectal cancer. It was a single institution study, and it ran over 6 years. Patients received preoperative chemoradiation 50.4 gray with infusional 5-FU. And they did institute a wait-and-see policy for a complete clinical response. The complete clinical response was based on physical exam, endoscopy, as well as MRI. And the MRI was a T2-weighted image with diffusion-weighted imaging that started in 2006. And they also started using USPIO to get better assessment of the lymph nodes from 2006 onward. They had a very strict definition of a complete clinical response. On the MRI, you had to have substantial downstaging with no residual tumor or only residual fibrosis, or low signal on the diffusion-weighted imaging when it was available. No suspicious lymph nodes on MRI. The endoscopy, you had to have no residual tumor, only a yellow pale scar, or a small residual erythematous ulcer or scar. They did take biopsies, and they had to be negative. And on clinical exam, there had to be no palpable tumor present. It's not clear to me how they assessed mid-rectal tumors or tumors that may have been higher to feel than lower rectal tumors, but maybe they just didn't include the clinical exam for those tumors. They assessed all of these at 6 weeks. They also, Habergamma also has never really shared her follow-up regimen very well, but they had a very strict follow-up regimen. They did digital rectal exam, CEA, endoscopy, MRI 4 times per year in year 1, and 2 CTs over the first year. And then this gradually got a little bit less over the 2nd to the 5th year, but there was very close follow-up of these patients. They, over the 6 years, had 21 patients out of the 192 who had a complete clinical response. So I think that response rate's a little low, about 10%. The mean age of the patients was 64. The majority were male. Several of the patients were going to have a planned APR, so they were low rectal tumors. They had a follow-up, median follow-up of 2 years. And they had a lot of T3 tumors. They also had some T2 tumors, although that was not in the inclusion criteria. But the majority of patients were T3 or more tumors, and the majority of patients were node positive. They compared this to sort of a matched control to patients who underwent resection who did not have a complete clinical response. And you can see in the observation group here, one patient did have a complication from a stricture from the radiation and did require a surgery for this. There was 1 local recurrence out of 21 for a local recurrence rate of 4.8. The overall survival was 100%, and the disease-free survival was 89%. And these were comparable to the resection group. They also looked at bowel function. And this was the Memorial Sloan Kettering bowel function score. And these numbers are really the percentage of patients with these problems. So you can see that the observation group did much better, in particular with the influence of food on their bowel movements. Use of pads was much less. They had less problems with control of flatus. They were less likely to use irrigation. And they were less likely to have a change in their bowel habits. More recently, there's been a study from Lancet Oncology in 2015 by the group from Denmark and Alpelt. And this was looking at a higher dose of preoperative chemoradiation for watchful waiting in the distal rectal cancer. So again, this was a prospective observational study. There were 55 patients with T2, T3, and 0 to 1 rectal cancer, less than 6 centimeters from the anal verge. This study was multiple institutions in Denmark between 2009 and 2013. They gave 60 gray and 30 fractions to the tumor and 50 gray and 30 fractions to the lymph node basins. And this was with the IMRT with a concomitant technique. They also gave endorectal brachytherapy tumor boost of 5 gray in the final week of the external beam radiation. And this was given with Tegafur uracil, which is similar to 5-FU. They based their complete response rate on endoscopic evaluation only. They did do MRIs on the patients, but did not use that to base their decision. And they did not give adjuvant chemotherapy. And this is similar to the BEATS-10 study. They had 40 patients with a complete response, and the mean follow-up was 24 months. And the cumulative local recurrence at 1 year was 15.5%, and at 2 years was 25.9%. They found that the median time to local should be local regrowth, is 10.4 months. And 9 patients with local recurrence all underwent successful salvage surgery, and 3 patients with distant metastases, all of which were to the lung, were all salvaged. They had a 2-year overall survival rate of 100%, and local tumor control with CRT alone was 58% at 2 years, and they have no patients with uncontrolled local disease. And more recently, I've seen a paper from a group from Argentina, which actually had very similar rates. They only used 50 gray or sort of more traditional preoperative chemoradiotherapy, but they had a very similar regrowth rate of about 15% in their group of patients too. So just to add some food for thought or some fuel for discussion, our group has done some interviews, standardized interviews with patients, and we've asked them to give us their opinions about surgery and chemotherapy compared to a watch and wait strategy. And what we've done is a probability, a trade-off technique. We've given them a lot more information than this, but we've given them a very detailed outline of the treatment protocol for both options. And we start with a local recurrence rate of 0% for both options. At this point, most of them will pick deferral of surgery since the local recurrence rate is the same for both of the options. And then what we do is we start increasing the risk of local recurrence in that deferral of surgery arm. So we'll say, would you still have deferral of surgery if the risk of local recurrence was 1% in deferral of surgery and 0% in surgery? And we continue to increase the local recurrence rate in the deferral of surgery arm until the patient says, you know what, that's too high now. At that point, I would switch over and I would have surgery. So this is a pretty busy slide. I'm sorry about that, but I'll try to explain it. So this is basically, we interviewed 50 patients in this standardized manner, and they could obviously choose their risk of local recurrence actually could go anywhere from 1 to 100%. And you can see that their answers ranged across the full range of values that they could have. 9 patients, when we said the risk of local recurrence is 0% for APR and 0% for deferral of surgery, said, you know what, I would just have the surgery. I want to do the biggest thing, the most aggressive thing, so I don't have any regrets, and I'll just have surgery. So 9 patients would pick APR up front, but you can see here 5 patients would continue to have deferral of surgery even if the risk of local recurrence went up to 100%. They'd still prefer this surgery. So here is just sort of the, these are the patients who said that they would accept a 1 to 5% risk of local recurrence before switching over to having an APR. And so the median switch point, or the median local recurrence rate that the patients would accept before they would switch over to APR and have surgery with a permanent colostomy was 20%, and the interquartile range was 2 to 50. What's pretty interesting about these results is we purposely interviewed 25 patients who had a low anterior resection. They may have had a temporary ileostomy or not, but they did not have a permanent colostomy, and we interviewed 25 patients who had an APR. And you can see that the results in terms of the local recurrence rate that they would accept were quite different. That the low anterior resection patients would accept a local recurrence rate of up to 30% with an interquartile range. Sorry, I can't even read that. I can't even read that. Sorry, that's sort of mixed up. Of 30%, and the APR group would actually only accept a risk of local recurrence of 4.5%. And it just probably reflects that nobody really wants to have a colostomy, but once you have it, you usually do quite well, and your quality of life is similar or the same as patients with a low anterior resection. So I think what's going to happen in the future, I think that probably it's going to be like breast cancer, that we're probably going to be talking sort of similar like mastectomy versus lumpectomy, that probably with rectal cancer we're going to be talking about TM, like do you want TME surgery or do you want organ preserving strategy? And David Seabart Montefiore is heading a study called STAR-TREC that I think will be pretty interesting. It hasn't started yet, but they're planning on randomizing patients with T1, T3, and 0 tumor to either TME surgery or to an organ preservation strategy that includes short course radiotherapy or preoperative chemoradiotherapy. And patients who have a complete response will have deferral of surgery or watch and wait strategy. Patients who have a partial response will have TEM surgery and will be converted to TME if they have have a greater than equal to or greater than T2. And if they have no response, will go to TME surgery. It's pretty interesting in Europe. I don't get the sense in North America, but in Europe, It's amazing that they're able to randomize patients to these trials of radical surgery and local excision. I get the sense that a lot of patients would pick the local excision and not agree to be randomized. So it's amazing that they'll, and they have shown throughout all their studies, they're able to randomize patients to these studies. So I think that this will be a very interesting study to see. And I think that's probably the way things will go. We'll start talking to, this is the way we're going to be sort of explaining things to patients in rectal cancer in the next couple of years. There's a lot of assumptions about all of this that, you need to have high quality MRI, you need to have high quality restaging MRI, you need to be comfortable reading those MRIs, you need to have accurate interpretation of the MRI and the restaging MRI, you have to have high quality local excision surgery with TAN and TANUS, you have to have high quality follow-up of these patients, you have to have high quality surgery of the suspected local regrowth and recurrences, and high quality salvage surgery as well. And so to do all of this, it's really a multidisciplinary effort, and it involves a lot of discussion with ourselves, but also with our patients to decide what the best treatment strategy is for them. And so I guess in summary, I might have confused everybody with all of that, but what I would probably say is the current best evidence and standard of care right now is preoperative chemoradiotherapy, followed by TME surgery for all stage 2 and stage 3 rectal cancer. I think that the surgeon should be encouraged to audit their laparoscopic results, that it may not be as great and as safe as we originally thought it was based on the studies that have come out. And probably if we have some more population-based studies to look at outcomes, that will be helpful. And I think that we'll await the results of Prospect and QuickSilver to see if primary surgery for good prognosis rectal cancers may be a treatment strategy that we use in the future. In terms of organ-sparing approaches, I think that we really have to await the results of the TREC trial and the STAR-TREC trial. And I think that really you can only offer these strategies in the context of an institutional policy or a clinical trial where outcomes are being monitored and that there's a multidisciplinary decision being made. And the patient must be, if this is going to happen, the patient must be aware that this is not the standard of care. And currently our QuickSilver group, actually, we have just submitted a grant with 8 centers across Canada to look at deferral, do a phase 2 study for deferral of surgery, looking more at the BEATS-TAN approach using MRI endoscopy to assess complete clinical response. So, I think that we're sort of accumulating some data. Unfortunately, with all of these trials, it's very hard to do a randomized control trial because there's not a lot of patients, and it would take a lot of time to do and money, and it would be an international sort of group that would have to do these trials, which has been done, but is very challenging. So I think that's it. If there's any questions or comments.
Really enjoyed that. Any comments from the audience? Jody?
Erin, that was great. Thank you. That was a really good overview of a lot of the phase 2 studies that are coming along. So I'm intrigued by the study you showed. I think it's definitely one of the European ones, but the one where they actually did the boost and brachytherapy at the end. And yet their local recurrence rates were quite a bit higher than some of the other studies, even though they gave more radiation. And it wasn't totally obvious to me from the inception cohort criteria, but was there any discussion about that or thought about why it was so high?
It's funny because they were giving a much higher dose of radiation with the boost, so I don't know why it was higher. I don't know. Like, it didn't seem like they were recruiting different patients, but I think that this is probably a pretty honest group that reporting their results. And the other study that I have seen, it's not published yet, but from Argentina, their regrowth rate was 15% as well, although they were using sort of a more traditional local recurrence rate.
Erin, can you comment on the philosophy or the preferences of our surgeons in our immediate community? Are they, if you have a randomized trial that, as we're proposing here, do you think the physicians themselves are likely to want to support the organ preservation approach? What's our community like?
Well, I think the surgeons, I mean, as a surgeon, I think I'm very, I'm a proponent of the organ preserving, like I'm very interested in it. And because I have to say, it's pretty, an APR is a very morbid operation that you guys probably see all the patients that do well and don't have, the ones that we, you don't see necessarily the perineal wound breakdown, the perineal hernias, and I think that although people are okay, that I think that it does affect their ability to do things. So I think that it's a big deal to have an APR. And it's also pretty hard to, it's not a great feeling as a surgeon to have done an APR and then tell somebody they've had a pathologic complete response and there's no tumor in their specimen. And it's something I warn the patients about ahead of time. And you're saying, oh, this is really great, you're going to do great. And you're thinking, oh my God, I just gave this person a permanent colostomy. So I don't think there's a lot of, and I think a lot of the surgeons feel that way, that I think we do feel that the surgery is morbid. They do have bad bowel and functional and sexual function results after TME surgery. And so I don't think there's any resistance from the surgeons to do this. But I don't think they're going to but I don't think anybody's at a point that they're just going to start doing it in clinical practice, because there's not a lot of evidence, and it's also hard following them. Like, it's not a great feeling following them when you're like, should I be operating? Should I follow them? So it's hard.
John?
I know with your CPAC, your CPAC role, and you have a national perspective with your CCO role, I also know you have some provincial insights. You don't think with detail yet, perhaps not right for prime time. But with all the randomized data in the Mercury, do you get a sense that the variations in practice for rectal cancer are in fact increasing in the last 15 years as opposed to becoming more consolidated in an evidence-based way?
I don't know. I think it's really hard in rectal cancer, because I think it's really hard to do randomized control trials. Like, even when we talk about the Mercury and the German study, and now we're doing this QuickSilver study, when I ask the group, what should be our next step? And they say, oh, let's do a randomized control trial. And I think, oh my God, that's going to be an international, to get the number of patients we need for a randomized control trial is going to be an international effort. It's going to be billions of dollars. Where are you going to get that money from? It's going to take at least 5 to 10 years 5 years maybe to recruit patients. We know across Canada, it's taken us 2 years to get 75 patients with 16 centers. So it's going to take probably 5 years to recruit patients, 5 years for the results to accrue. And so it's a big problem, and I don't know what to do about it. Like, ideally, yeah, we should have a randomized control trial, but the feasibility of that is very challenging. And it's going to be the same thing with preoperative chemoradiotherapy with local excision, because you're starting to select these very specific patients, and there's not tons of them. So it's very challenging. So I don't know if anybody has any other thoughts. So it seems to be, we're probably, with our group, with QuickSilver, we may continue just to keep sort of on a study protocol and keep collecting data over time. And as a group, sort of decide, should we just sort of adopt this? But that's not ideally what we should be doing. So I don't know if there's anybody could comment on that.
I can't comment. So the whole thing about the shared decision-making and patient preferences, people may not know, but this is like Erin's expertise.
Mm-hmm.
One of the many. So when you were showing that data, I always feel there are many, many patients who can totally engage in and understand that conversation, and there are some who just seemingly have a lot of difficulty. They have very fixed ideas. And when you're showing your data, and you showed there were some patients who actually said they would want to have chemoradiation and watch and wait even if there was a 100% risk of recurrence, which is kind of not a very rational decision to deciding on a completely ineffective treatment. So what is your feeling in interviewing these patients about who gets it and who doesn't?
You know, I think that I think they all, like, we haven't had anybody completely not understand it. We do a knowledge test at the end, so we ask them if they understand, you know, what their risk of local recurrence is. And we're pretty gruesome when we explain local recurrence. Like, I think we weight it towards them thinking local, like, you know, tell them, you know, you'll have terrible unremitting pain, you might need a big operation, including, so I think we're quite honest about it. In terms of the patients, they all say that, I think I have some other cards here, but I'll just show you. So this is sort of some of the cards that we show them, talking about sexual function and stuff like that. But they all seem to understand it, you know, and they all seem to think that they all like the decision aid. And they all think, we sort of worry that we're giving them too much information, and they all ask for more information. Like, they all think that it's not enough information, which is interesting. So we haven't, and the other thing is that, you know, it's always hard doing these studies because you don't want to do it on patients in real time because of ethics, and you don't know, you know, you don't want everybody to get upset if they pick, you know, the watchful wait option, and, you know, and so we're doing it either in patients who don't have rectal cancer, which is hypothetical, or patients who've had surgery, so it's always hard. But I think they understand it, and quite frankly, you know, Michael Solomon's done a paper looking at colostomy in physicians, and actually, you know, the physicians are probably even more irrational than the patients. The surgeons, the medical oncologists, and the radiation oncologists in that study, they would accept a 20% loss of life to avoid a colostomy. You know, you're not going to die from a colostomy, so. They would rather take a 20% loss of life than have a colostomy. So, you know, it's very hard. And local recurrence, like, the concern is that patients don't understand local recurrence because they don't know how bad it is. You know, they probably, you know, which is probably true, but so it's also really challenging.
In thinking about picking these patients, it would be nice to have functional imaging, biomarkers up front that would predict who are going to be these favorable responders. So in thinking about the next step, are there any favorite biomarkers that is in the horizon that can be incorporated?
I don't know about biomarkers. I know that we've done a sort of pilot study looking at CT PET with MRI, infused with MRI, and we haven't found that it's improved things significantly in detecting a complete or pathologic complete response. I also know that we're looking at a study looking at hypoxia, so looking at the FES study to see whether you know, the patients with more hypoxia are going to have a better response or not. But I don't know of any biomarkers right now.
More questions? Maybe one final one in terms of evaluating response. Do you think there's more gains to be made in any imaging, or kind of at our plateau in terms of imaging and detecting whether we got a complete response?
I think that, you know, we sort of, our group here, we have decided we'll do restaging MRI on all the rectal cancer patients so that we have a better understanding. I think that the radiologists, you know, and all of us haven't seen a lot of those scans and know what a complete response looks like. So I think we all have to get used to looking at those scans and sort of then looking at sort of the final pathology to look at that. But I don't think I think it's going to be hard on any imaging to see, you know, one small cell or a little island of cells that's left over. So I think it's going to be hard with imaging to do better at selecting those patients with complete response.
Well, Erin, I can't thank you enough. This field has really been evolving and actually very complicated. So I really appreciate you pulling it together for us and put us in a very good place to start further dialogue and supporting the trials.
Great, thanks.
Thank you.
Your conference is scheduled to end in 2 minutes.
I'll look at it. I will. I can't remember where I was. I did it.
So we started to see a response.
Oh yeah, after how many days?
7 days.
Seems like too long.
And you know what? You go for so the tumor on the one side is really growing.
Yeah.
The other one is still.
So you
It
get
didn't grow as much. Yeah, it didn't grow as much.
okay, so it's still growing.
I asked about the neighborhood.
Yeah. You know, you have to have a shit. Yeah. Yeah. Well, it's waiting for all.
Your conference is now over. Goodbye.
And it just shows that the APR patient is actually given them dose again with is that a confirmation bias or is that an indication of
always find people tend to be on that side of the Did everybody get a chance to sign in? Someone signed for Princess Margaret, and I can't read the first name. So the last name sounds like you. Okay. Are you going to discuss this? Okay, tell me how it will help. Did you submit your parents' form or the time ready to submit? So let's do it together. Yeah. So you're going to sign something. So she's the sign. Excuse me, so what's your name? Do you want to just sign at the bottom of Princess Margaret? Can you see me, make sure you see me at the end of the presentation? Are you here for voluntary rotation? So come on in, that's not our sign sheet, first sign sheet. This is for a regular session.